Okay, I'm just going to say I wanted to introduce David. It's a great honor and a pleasure, and everybody knows him, so I keep it very short. Everything I said was lost in space. So, David, please go ahead. I'm very excited to hear you.
Thank you, Ingrid. First of all, we believe we have about 700 people signed up today. And so we have people from all over the world, obviously. And we're going to have people of different experiences. We have, I'm sure, some new people to ophthalmology, veterinary ophthalmology. We also have some
A pleasure,
diplomate
and I'm
ACVO and ECVO, and so we're going to have a fairly wide spread of experience. The first thing I want to do is I want to say thank you to Mrs. Fromberg and Vision for putting this together and sponsoring this for us. And so Ingeborg, thank you so very much. She's probably somewhere in the background. And a great thank you to Ingrid Allgauer from Animal Practice in Berlin. Ingrid and I lecture all often together. We do the Vision course in Berlin, and we obviously didn't last year because of COVID. And we've certainly done some other courses together. And she's a phenomenal speaker, and I'm honored to have her as moderator today. What I will say is the topic today is Phacodynamics and kind of principles of Phaco. When we do this course in Berlin for Vision, it's a 3-day course. If you want to start talking about all the ins and outs of cataract surgery complications, both pre-op, intra-op, and post-op. And so we're in no way, shape, or form going to cover all complications and all bits and pieces of cataract surgery. We've got about an hour and a half to 2 hours today. As I said, we have perhaps up to 700 people, which shows tremendous interest in the topic. And it also tells you there's going to be an awful lot of different experiences and different opinions. And so the first thing to say is, I'm going to tell you about my opinions and some of my experiences, but everyone has an opinion. Everyone is entitled to their opinion. And so please respect, listen, learn, and adapt. The worst thing you can do is be rigid and say, this is my way, because you will no longer be adaptable and learn. And we'll talk about why that's important. For the purposes of today's discussion, our goal is small incision surgery and phacoemulsification, and that will apply when we touch towards the end of this to lens luxations, partial and total lens luxations. Our goal is still small incision surgery where possible. And then the second part of the goal is emmetropia restoration, so getting them back to an emmetropic level of vision using an intraocular lens implant. So that's our goal. We don't always achieve our goal, but that's our goal. About 50% of the time, I'm a one-handed cataract surgeon, meaning I have one instrument in the eye, which is the Utrata, the coaxial phaco. And Ingrid, when we teach together, is fairly similar in this, I think. And I do that without hydrodissection for the routine cataract. However, I will do a planned two-handed, and we'll talk about two-handed. I will do a two-handed surgery when indicated, and I will convert if I get into a surgery where I think it's a one-handed procedure and I encounter an unstable lens or a hard lens. I will convert to two-handed quite comfortably. And so I'm adaptable. I do both. And I know some young surgeons think we just do two-handed all the time. And I'll give you some data from the human literature that says you might not want to do that. There's absolutely no reason to do two-handed cataract surgery in a 18-month-old Siberian Husky. There just isn't. The lens is so soft. There's rarely an indication in most diabetics, which are already intumescent and split along their suture lines, unless perhaps there's a capsule rupture. And so it's okay to do one hand and two-handed and be able to be adaptable in both. And we'll talk about that. My residents get sick and tired of my telling them this, but Mitigating and minimizing trauma. Time is trauma, plain and simple. The eye does not like to be operated on. It doesn't like to have you inside it. It doesn't like you handling it. And so time is trauma. Your surgery time from cut to closure, from the time you make a 2.8 to a 3.2 millimeter groove, entry, visco, to the point that you tie that last suture, 10 to 17 minutes an eye. That's a goal. Will you achieve that in every case? Nope, you won't. But it's good to have a goal. And when you start talking about 30 minutes and 40 minutes and you wonder why you're having complications, one of the things that I get frustrated with surgeons is we tend to blame everything but ourselves. It's the dog. Oh, it's a bad breed of dog. It was the viscoelastic. It's the IOL. Ultimately, you're the captain of the ship, and you have to own complications and go back to asking why. Phaco time, 0 to 120 seconds of actual machine time running. Most eyes, it's 10 to 60 seconds. That's a goal. And I challenge when I would operate one eye, the resident would operate the other. The challenge is for them to achieve similar times. Fluid volume. We're running fluids through the irrigation aspiration. Again, that's trauma. 50 to 200 mLs an eye. Goal would be better even at 50 to 100 mLs an eye. So those are things to keep in mind. We need to just touch on some foundation principles of microsurgery because that's what we're doing right now. And so there are rules of microsurgery, and the rules are a foundation or a guide that need to be used for the beginning surgeon. Can you break the rules? Oh, absolutely. I'm a rule breaker. Once you have mastered the rules, once you understand the rules, yes, there are ways that you can break the rules, that you can do things that make you faster, that make you more efficient, that you can adapt. But as a learning surgeon, no, you don't get to break the rules. You follow the rules until you understand the rules. And when you get in trouble, when you're struggling, go back to the basic rules and principles. Go back to Gillette, read the principles of microsurgery, body position, hand position, elbow position. Understand the basic rules of microsurgery and go back to those. So many times when I see a young surgeon struggling, all I need to do is actually come back from the microscope and not look through the scope, but just come back and look at the overall position of that surgeon, body position, hand position, arm position, and you'll see sometimes why they're struggling. You have to have a goal. The goal in this case is emetropia with an IOL, but you have to have a goal. I'm going to start at position A, and I have a goal to go to position B. Okay, but you have to be adaptable. We're going to look at that in a second because how I get from A to B doesn't work the same in every case. Our goal was the gold medal. I am a Canadian. That is actually the north of Canada in my background. That's the Ray River where I try to spend my summers canoeing in the Arctic. But the goal in this case, this is the 2010 Olympics in Vancouver, and the goal is hockey and the gold medal. That's Sidney Crosby with his arms in the air, and we've achieved our goal. We had obstacles in our way. They were called the Americans, and they tried to stop us achieving our goal. You will have obstacles in your way in cataract surgery, and you have to overcome those obstacles to achieve your goal. And realize not all surgeries are going to go according to plan. You're going to get in there at times and things are not going to go the way you thought. All eyes are different, and the surgeon who says to you, I always do it this way, I always divide and conquer, I always do one-handed, I always phaco chop, you're going to encounter situations where that technique does not meet the needs of that patient. So you need to know more than one technique. So many times when I'm sitting at the table with a young surgeon learning how to do cataract surgery, and they just keep doing the same thing with no forward progress. The phaco time is going up, the fluid volume is increasing that's running through that eye, and nothing has made forward progress. And the first thing I go is stop. Is what you're doing achieving your goal? The answer would be no. Then why do you keep doing it? What are your goal, like your commute to work every day, Every day you wake up in the morning and every day you go to work. We all got to work. Everybody in your clinic, everybody in your hospital got there, but they all came by a different way. Some came by car, some by train, by bus, by bicycle. Everybody took a different way to get to the same destination, and they all achieved success. You don't have to take the same path to get to the goal or the destination. You just have to get to the destination. So here is the veterinary hospital at Ohio State University. That's where we're going to work. The mentor lives here, the boss, the staff lives here, the resident lives here. We all have to get to work. We all started in a different place. We all have to achieve our goal of getting to work. And in this lecture, the goal is to go from that cataractus non-visual eye on the left to that phaco IOL emmetropic eye on the right. That's our goal. But there's obstacles in your way. You have a way every morning that you get up and go to work. But what if on the way to work today, there's construction, there's an accident, I can't go the way I normally go? What do? Do you just sit there and wait? Or do you know another route to get to work? And so if that road is blocked, if there's an accident, I know how to go around it and still get to my destination or my goal. So if your goal was a one-handed phaco and that lens is unstable or that lens is hard and your plan of a one-handed phaco isn't working, then convert to two-handed. Understand that if your divide and conquer wasn't working, maybe it's a phaco chop maneuver, and we'll look at all of those on videos. Regardless, you follow the basic rules. Appropriate magnification and instrumentation, efficiency, precision, minimal tissue trauma. Trauma is everything: fluids, phaco, forceps, cutting, suturing. Minimize that and be efficient. Shorten surgical times, maintaining the chamber using small incisions and viscoelastics, putting things back together with small and delicate and precise suture techniques, and getting an end point of a comfortable cosmetic and visual outcome. Those are our fundamental goals. Keeping the principles in mind that time is trauma, the tissue should be handled as little and as efficiently as possible. If you touch something, then do something with it. If you're not ready to move forward, don't touch it. Okay? Think of surgery, cataract surgery, as a series of steps in sequence: A, B, C, D, and be prepared to move efficiently from step 1 to 2 to 3 to continue the forward progress to minimize the amount of time that you're there. So those are some basic rules. Phacoemulsification, we can thank this man, Charles Kelman, father of phacoemulsification. In 1962, he invented the cryoprobe. In 1966, he did the first animal phaco, and in 1967, he did the first human phaco, which took 76 minutes. That is the machine that, in this image right here, that is the original phaco machine. It was a dental unit that, an ultrasonic unit that he converted into phaco. We've come a long way since then. The technology and the techniques have evolved rapidly, and I encourage you to look at the literature, be they textbooks, be they journal articles, publications, to stay up to date on new techniques, to take a look at publications by breed or by disease, for example, diabetes. Where can we achieve better success? And keep in mind, there are failures, and this is not veterinary book. This is Phaco Nightmares. It's a human, and there is actually a second edition, a second volume out. And so be prepared. There are going to be obstacles. There were going to be complications. Keep in mind reading the veterinary literature. That's just a quick search on the keyword phacoemulsification. In the last 3 months, 6 publications on phacoemulsification. In the last 6 months, 12. In the last year, 28. So there's lots of ongoing, continuous publications in this area. And I encourage you, if this is your area of interest, that you continue to stay current with the literature. It's a technology-driven procedure. There are lots of phaco machines. There are lots of different options for you out there. And it depends, obviously, on your financial abilities. It depends on where you are in terms of numbers of cases, what sorts of units you're looking at, but you get what you pay for. These are all vehicles. They will all get you to your goal. They will all take you from A to B, but they will do so in different ways, in different levels of efficiency. And so that's the old Trabant. It'll get you there, but if you buy an old phaco machine like that, it's going to be slow. Right? Here's one that's been cut in half and is being pulled by a horse. Incredibly inefficient, that machine. So too are many old phaco machines. So shall I buy a fancy phaco machine? Do I need a Lamborghini? Do I need a sports car? There depends on what you're doing. Are you doing vitrectomies and posterior segment work, or am I only interested in anterior segment? But here's the thing to know. When you buy a machine, a new machine, a nice machine, like those sports cars, this sports car comes with a gear shift. In this case, it has reverse and it has 6 gears. The thing that frustrates me is so many surgeons with a phaco machine never change gears. You bought a very fancy machine. It's got incredible versatility. You can adjust the needle tips. You can adjust the presets for phaco energy. You can change the flow rates. You can change the vacuum. But when I talk to a lot of surgeons, all they do is turn it on. And they use whatever setting, perhaps the sales rep put it on when they set it up. And they never change. Well, the animals change, the lens changes, and you bought a very powerful machine, and yet you're driving it in first gear all the time. And so you need, as the surgeon, as the captain of the ship, you need to know what all those buttons do and how to adjust them. The principles of phaco, the handle is going to deliver ultrasonic energy, and then the fluidics, irrigation, basically based either on bottle height or the machine with sensors and pumps, and aspiration based on flow rate, based on vacuums that you have preset. And we're going to look at those. All of it's going to get controlled by a foot pedal. And so you need to be able to understand the foot pedal, and different machines have different foot pedals, which have different settings on them. So you need to know the foot pedal of your machine, and you need to know it as well as you know the foot pedals in your car. You don't have time to think about it. When it's time to go from the gas to the brake in your car, you don't think about that. You just do it. It's reflex reaction. You need the same ability on your phaco foot pedal. The ultrasonic energy, basically what the phaco handpiece does is it takes, you plug it in the wall. It converts electrical energy into mechanical energy. It does so through what's called stroke length. The tip vibration, we're going to look at that in just a second in a little more detail, but basically that tip is moving in and out, that is stroke length, and in doing so, it's creating impact effect on the lens, it's creating cavitation, it's also generating heat and thermal damage at the cornea where it goes in. This happens to be the Ortley machine that AnVision has. There are all sorts of buttons on this machine. Phaco 1, Phaco 2, Phaco 3. There's pulse settings, there's vacuum settings, irrigation, there's capsule settings. And you can see there are presets here. Phaco 1 has a flow rate of 20 and a vacuum of 100. This happens to be a manufacturer's suggestion. You can adjust it for you. Phaco 2, Vacuum and flow rate change. Flow rate's up to 40, vacuum's now up to 400. Phaco 3. And so as we go from a solid lens, a whole lens, into chunks and fragments, we're going to adjust the flow rate because we're going to adjust the vacuum. We want a stable eye, and we'll look at that. And many of you may have different machines. You may have the Bausch & Lomb. One of the most common ones in the veterinary world right now is the Ortley machine and the Stellaris Elite. And so again, you can program those settings. You can see all the settings up here on your screen. So here's what the Phaco handpiece does. You plug it in the wall. It has piezoelectric crystals inside it. Those piezoelectric crystals, when you step on and apply electrical energy to them, expand and contract. So they go in and out. They get thicker and thinner and thicker and thinner, and there's a series of those. And as they move to the electrical energy applied, they're going to generate stroke length at the tip. They're going to move that tip in and out like a jackhammer, like a fist going back and forth, and they're creating mechanical energy that will impact that lens. In order to get to that, you have to have fluid flowing. And so mostly we're going to be doing what's called coaxial phaco or coaxial procedures, which means the irrigation and the aspiration go through the same incision. So here's the bottle. The red is the irrigation through the handpiece. The blue is the aspiration through the handpiece. And so we have an irrigation line, we have an aspiration line, we have a pump that we'll look at that controls those, and we have a stroke length, a movement of tip that takes place here. So when you step on that foot pedal, it controls in the phaco mode three things: irrigation, irrigation aspiration, irrigation aspiration phaco. Okay. Now, the tip of that phaco needle is what does the cutting. That's what is going to impact the lens. And you can change the tip. You should pick a tip based on how hard you think that lens is, based on the skill of the surgeon. And so you can see 0 all the way to a 45-degree cutting tip. The more acute the angle, the sharper the needle. So a 30-degree needle is going to cut better than a 15. A 45-degree needle will cut the best of all four of those. Okay? It's sharper, so it's faster, but it's also more dangerous. So let's look at that. As that tip moves, as that phaco moves in and out, as you go to position 3 and create the stroke length, you generate heat. It's moving through the corneal incision. The old machines are less efficient. When you get I got a free phaco machine. Yeah, if it's a really old generation, inefficient machine, what you're going to find is it takes a long time to achieve your goal, and it creates a significant thermal effect. This is a thermal burn of the cornea that has been created by the phaco needle. It melted the stroma, it heated, it caused coagulation necrosis of that corneal stroma from heat. The newer machines are more efficient, they generate less heat. And the other thing that you need to keep in mind is the fluid is cooling that heat. And so the irrigation aspiration fluid and a little bit of fluid that may be leaking even around your incision is cooling that. And be careful of that you don't pinch off the infusion line. When you put that needle in the eye through that incision, if you turn that needle 45 degrees because you want to go to get a piece of lens way over to the right or way over to the left, as you turn that, you pinch the sleeve that's bringing the irrigation fluid. You pinch it in that corneal incision, and you temporarily shut off the fluid flow. You step on the phaco and the chamber seems to collapse or shallow on you because you've compromised the irrigation. Not only have you compromised irrigation and you're getting chamber collapse, that's trauma, but you've stopped the ability to cool the thermal effect in the cornea. You're going to get more thermal damage. People, when they get phaco equipment, want to know, should I be disposable or reusable materials? We used to use a lot of reusable materials. Most of what we do now are disposables. Okay, how cost effective is it cleaning and reusing? How long can I reuse them? How do I clean them and sterilize them? And so majority of the new machines, these are going to be disposables. The tubing, the cassettes are going to get thrown out between patients. So the only thing that you have to handle and clean is that phaco handpiece typically. When you step on the foot pedal, and you go to position 3 and you engage the phaco, you begin the process of moving it in and out. It moves in what's called the stroke length, which is generally 2 to 6 mil, which is thousandths of an inch. That's about 0.1 to 0.12 millimeters. The phaco foot pedal is like the gas pedal in your car. The farther you push it down in position 3, the faster your car goes, the longer the stroke length becomes. And we're going to look at that in just a second. But the longer the stroke length, increased heat, increased cavitation, which we're going to look at. Those are bad things. Increased physical impact on the lens, that's a good thing. That's cutting the lens. And so you want to find a balance. I want to use the minimal amount of energy to achieve my goal. So you don't just push the foot pedal to the floor. If all I need is 10 or 20% of the stroke length, then that's all I need. If it's an 18-month-old Siberian Husky, I don't need a lot of energy. But if it's a 15-year-old miniature poodle, okay, I may need a longer stroke length to achieve my goal. Look at the consequences of reuse of materials. This is a new phaco tip, and that is a reused phaco tip. Multiple uses, maybe 20, 30 uses. But look at this is metal. Look at what's happened to the metal. And how on earth is that possible? How can the lens and the aqueous, how can the fluid do that to a piece of metal? It's called cavitation, and we're going to look at it in just a second. And we're going to see cavitation is a pretty powerful thing. This is reused tubing that's not been cleaned properly. So there's bits of material in there. Could be lens material, could be dried saline material, dried lactated, whatever solution you're using, BSS. And that is in there, and it's going to be flushed into the eye potentially on the next surgery. Okay, and so if you are cleaning things, please clean them well, irrigate them with distilled water, sterilize them, make sure that you replace your phaco needles periodically, because this is what's happening to them over time. Things that have hollows, tubing, hand pieces, do not gas them. Because if there's any liquid trapped inside that tube, if there's any liquid inside that handpiece, you did not sterilize it. So I irrigate my tubing, I irrigate my handpiece with distilled water, I then blow it with air, but then I autoclave it. I use heat, steam, routine autoclave, flash autoclave, not gas. Not for your phaco tubing and not for your phaco handpieces. You need an autoclave to make sure they're sterile. And my residents get mad at me. Everybody does the dishes. Clean your own instruments. Nobody is above knowing how or performing the task of cleaning the materials. Distilled water for cleaning your instruments, delicate wipes and brushes for them, avoiding instrument-to-instrument contact, not your phaco handpiece, but your other instruments, micro instruments, spraying them with instrument milk. Everybody helps clean these and keeping them clean so that when you go back to the next case, everything is where you want it to be. So back to stroke length. Stroke length controlled by your foot pedal. It ranges, different machines have different frequencies or hertz, 35 to 45,000 typical. Lower frequencies, less efficient, higher frequencies, more cutting, but more heat. And how does it work, that stroke length? It creates a jackhammer effect. It physically hits that lens, okay? But it also creates cavitation. And cavitation is both your friend and your enemy. Cavitation is the formation of bubbles and their immediate implosion within a liquid. And cavitation is created when the phaco needle moves forward and it occupies space, and then that needle moves back. And for a fraction of a second, a fraction of a microsecond, the needle left an empty void. It was here and now it's not. And things have to rush in to fill that void. And it creates turbulence and it creates cavitation. Those microbubbles are very powerful, not globally, but at a cellular level. When those microbubbles form and implode, they create effective temperature and shock waves that help to break up a lens. But they also damage corneal endothelium. They can damage vasculature of the uvea. They can create issues in terms of post-op fibrin, uveitis. And so the more cavitation, the quicker you're cutting that lens, but the more side effects that you're getting. So let's look at cavitation in two ways. This is a propeller from a boat. And this is what that propeller looks like as it moves through the water. It's spinning very fast. And as that propeller leaves, as it was here and then rotated, it leaves these cavitation bubbles behind. So does your phaco needle. The phaco needle moved forward with its stroke length and then moved back with its stroke length. As it moves back, it leaves a void. That void must be filled. It's filled by inrushing of fluid, which creates bubbles and turbulence and cavitation. Okay. So the destructive events of that phaco needle are the cavitation, are the shock of the acoustic wave that's being created moving forward, by the mechanical impact, just physically striking the lens. All of those are helping us to break that lens up. But look at what cavitation does. Look at this boat propeller. It didn't hit any rocks. It's simply spinning through the water. It's made of stainless steel. And yet the water has done that to the edge of that boat propeller by cavitation. It's the same effect on this phaco needle. Cavitation is so powerful that it can actually pit and damage hard metallic instruments like propellers and phaco needles. Imagine what it does to lens, to iris, to corneal epithelium. So we're going to use cavitation to achieve an effect, but we want to minimize it. And so we want to use as efficient and short a stroke length as possible. We want to use as short a phaco time as possible to try to mitigate that. And then we want to change our needles periodically, because this needle is going to create massive amounts of cavitation compared to a new needle. Every imperfection in the metal generates more cavitation. And so a smooth phaco needle generates less cavitation than a used needle with edges that are rough and pitted. Not only is it less efficient, but it's causing more cavitation. The cavitation creates free radicals. Now look at 3 papers. This is from the Journal of Cataract and Refractive Surgery. Hydroxy radical generation during phaco and the damage that it can do to the adjacent tissues. Okay, High pressures and temperatures are released on implosion by cavitation bubbles generated by that phacotip. And it's generating hydroxy radicals, free radical scavengers that are cell toxic. Here's one from VetOps 2006. This paper looked at free radical scavengers, ascorbic acid, and antioxidants in the aqueous. And they showed that over the course of Phaco, we used them up because the Phaco generated free radicals. It generated hydroxy radicals, and the ascorbic acid and the free radical scavengers that help to protect were being consumed. And so we showed that, yes, we generate them, and yes, we try to react to them. And we also know that things like sodium hyaluronate that we use is a free radical scavenger. Okay, and so we can do some things to mitigate this. Viscoelastics are free radical scavengers, sodium hyaluronate. There's natural occurring free radical scavengers, and you as the surgeon are going to be responsible. And you're going to use a good needle. You're going to use a sharpened needle as you need, 30, 45. We'll look at that in just a second. You're going to minimize your phaco time, and you're going to only push the pedal on the floor down as much as needed. So what needle do I pick? Generally, it's a 30 or a 45 for most of what we're going to do. And I'm going to tell you, I only pick a 45. I'm an impatient surgeon, and I'm very comfortable with what I'm doing. And so I'm going to pick a 45 for me. It's fast, it's quick, it's efficient for me. But I also taught residents for 30 odd years. Residents should not start with a 45-degree needle. They should start with a 30. If you're a beginning surgeon, do not start with a 45-degree needle, and don't start on a 15-year-old poodle. If you want to learn how to do this, start with a 30-degree needle and do so in a younger, softer lens. Pick one that's not going to be as difficult or as challenging. Not only can I adjust the angle and the sharpness of that needle, but I can adjust the design at the end. We can have what's called a flare tip, which is this one right here, where at the end it gets wider. We'll see why that can help. And we can have an angled tip, which the needle bends downwards, a Kelman angle to it. And so I'm typically going to suggest a 30 or a 45-degree needle, and I think you should have both in your pack. That's that learning surgeon, that young Siberian Husky, 30-degree is fine. That 15-year-old poodle, a 45. You need a sharper needle. The Kelman, which angles down, tends to direct the cavitation energy more efficiently into the lens. And so the Kelman tends to push the energy to where you want it to be. And the flare tip I like because it gives me, when I have a hold of a piece of lens, it gives me more holding power. And I'll show you that in just a second. So here's, look at holding strength. This is a 0 and this is a 45. You can see the cut end and you can see the radius, the R1 changes. And so it's got a bigger opening. It's got a larger lumen. So here's the effect of that. The vacuum is set at 100 millimeters. When you tip occlude at 100 millimeters of vacuum, the holding power of this tip is 0.0019 pounds. At the same vacuum, if you tip occlude, the vacuum holding is about 70% better. So how do I explain that in easy layman's terms? Do you want to hold on when you're climbing with one finger or all fingers? It's holding strength. So here's a piece of paper. I'm going to hold this piece of paper between my thumb and just my first finger. That's the surface area that I'm using. I can't hold it. I don't have the ability to hold. Let's increase the surface area that holds that paper, and I can't pull it out. And so when you go to a flare tip, when you go to a steeper angle, a 45, the opening gets bigger. It's harder to occlude, but when it's occluded, the holding power is tremendous. That means you can hold that lens with your vacuum while you hit it with your phaco needle. Fragments don't tend to fly away. So it's harder to occlude the tip, but when you occlude it, you own that piece of lens because the vacuum has a much greater holding strength. So it helps you to understand why different needles and different angles work in more efficient ways. So I'm going to tend to tell you a 30 or a 45 degree needle. I'm typically going to use a Kelman or an angled down because you can see it directs the cavitation to where I want it to be. And I'm going to typically use a flare tip. Having said that, that's not what you give to the beginning surgeon. Think of it like learning to teach a child how to use a knife. You do not hand that child this knife. We're going to be in trouble. So for the learning, beginning, early surgeon, start with a 30 degree needle. You don't need a Kelman, you don't need a flare tip, just get comfortable. Think of it like using a knife that's not as sharp. It's safer. You'll cut slower, but you will less likely burn through the posterior capsule. You'll less likely get yourself into trouble. As you become more comfortable and competent, then you can get sharper needles. You can increase the lumen diameters. You can do the things that make you faster and more efficient, but not at the start. I'm not going to give the learning surgeon a steak knife to begin. Okay, so talk to your rep. Whatever company you are using their phaco machine, understand there's all these choices. There's different needle lengths, there's different needle designs, there's different sharpnesses and angles, and they are customed for the machine you're using, and they all have matching sleeves. So there's a horse needle with a matching sleeve. There is a flared tip, right? And so we've got incisions 1.6 to 1.8, 2.2 to 2.4, 2.8. So the knife has to match the needle so that the incision matches the needle that you're using. Okay, so 30 degree, 40 degree, flared, Kelman, how wide an incision do I want? These are all decisions that you have to understand and work on. I said you want minimal phaco energy. So the stroke length on your machine, you can set a preset. You can ask anywhere from 0 to 100% energy. And the foot pedal delivers that energy. The farther you step on the foot pedal, the more the stroke length according to your preset. So I'm going to show you a graph of that in just a second. I want you to be efficient. We're going to look at pulse and burst modes in a second that will help you with that efficiency, and then picking a needle for the particular patient you're dealing with. If you're dealing with an old animal, a geriatric patient, dealing with a hard lens, that's when you start thinking about 45 degree Kelmans, flared needles, those sorts of things. So here's what I mean by preset. The preset on this phaco machine is 100%. The preset on this is 50%. So before I began the surgery, I told this machine that the most power you can give me is 50%. So when I push the foot pedal here all the way to the floor, in this one, it's linear phaco. So the more I push the foot pedal, the longer the stroke length. The farther you push the gas pedal, the faster the car goes. And I can get 100% energy. That machine is working as efficiently to deliver 100% energy. On this machine, I preset it at 50%. So when I step all the way to the floor, all I get is 50%, half the stroke length of the one above. So remember, most of us keep our machines set at about 70%. Your preset is 70%. Why do we need to remember that? Because if you're working on a lens that is harder than you thought, and I've gone to two-handed, and I've got a 45 degree, and I'm still finding it's not cutting the way I want, the preset's at 70%. My foot pedal's all the way to the floor, and I don't have enough energy. Stop. Ask the operating nurse to change the preset. Take it to 90%. Take it to 100%. You've got 30% more capacity you're not using because you had preset at 70%. That's remembering how your machine is set and remembering it's a safety that I set it at 70%. But if I need more, it's there and I can change that. So remember what your preset is. Fluidics, fluid in, fluid out. I need a stable chamber. I need to push fluid in to cool and to irrigate, and I need it to be kind of same rate as my aspiration, and I need aspiration to pull that lens out. Inflow is controlled based on your machine. Sometimes it's based on bottle height, older machines. Sometimes it's controlled through the machine. Outflow, multiple things control outflow. The tightness of your incision. If at the end of the surgery your feet are wet, you had a leaky incision, so some of your fluid went on the floor. Outflow is controlled by your aspiration rate, by your vacuum preset, and by how much vacuum you on your foot pedal demanded. If you're using bottle height, an older machine, there is a table that tells you how many millimeters of mercury for every 15 centimeters of bottle height. The rule of thumb, every 15 centimeters you raise the bottle above the eye, adds about 11 millimeters of pressure increase to the eye. So if you're using a machine where the flow is controlled by bottle height, and when you step on the foot pedal and you start the flow, that's irrigation, and then you step a little further to position 2, so that now I have irrigation and aspiration. When I did that, the chamber shallowed, the cornea came down. Then you don't have enough flow. You're pulling fluid faster than the bottle can maintain. So if you're running with an older machine, raise the bottle a little bit. You want a stable chamber. I don't want chamber bounce. I don't want to step on vacuum and watch my chamber shallow, right? Think of some of the ways we break blood aqueous barrier. A passive centesis, simply a needle in the eye, take a little fluid out, collapse the chamber, the blood aqueous barrier is broken. You get flare, you get fibrin, you get cells. Chamber bounce is just continually doing that. You don't want chamber bounce. So I need a stable chamber. The purpose of the fluidics is cooling at the incision and maintaining the chamber. It's doing both of those things, and they're both critical. Aspiration is pulling the lens out, the fragments. It's going to be controlled by the vacuum, how many millimeters of mercury. It's going to be, in some machines, controlled by flow, how many mils per minute we're pulling. And there are some machines that have what's called active fluidics. The Centurion has what's called active fluidics. And so the machine continuously monitors flow rate, irrigation pressure, vacuum, and adjusts them with a computer to try to maintain whatever intraocular pressure you programmed into the machine. So you tell the machine, I would like to maintain a target intraocular pressure of this, and then the machine does all the adjustments. What I will say, having used this machine, I don't like it. I find for me, it uses massive amounts of fluid compared to what I normally would. So an eye that might be 50 to 100 mLs of fluid, this machine for me runs 250 to 500 mLs of fluid with its active fluidics technology. And so I personally, for me, you may love it, you may have it, you may figure out how it works best for you. Didn't float my boat. Was not something I enjoyed. How's that fluid being pulled? You have basically two main systems: peristaltic pumps, which is what most of your machines will have, which is a wheel that turns over the tubing, and Venturian diaphragm pumps. Venturian diaphragm, the diaphragm simply moves the diaphragm in and out, creating a vacuum, and the Venturi moves gas across the system, creating a vacuum. What's the difference? Responsiveness. Peristaltic pumps are slow. They are safer, therefore. When I teach residents, when you teach surgery, peristaltic pumps are by far and away the best way to teach a young surgeon. So here's the way it works. You set the machine for 300 millimeters of vacuum. When you step on the foot pedal, first thing that turns on is irrigation, and then you step on aspiration. That starts the pump. The wheel begins to turn. There is no vacuum. It's just water in, water out. But when you occlude the tip, as soon as you occlude the tip with a piece of lens or iris or lens capsule, the vacuum begins to build. Now, I asked for 300 millimeters of vacuum. In this graph right there, I occlude the tip, and the vacuum begins to build to 300. It took some time. That was the safety margin, because you didn't tip occlude with lens, you tip occluded it with iris. You tip occluded it with the posterior lens capsule. And the first thing your mind says is a very bad word. And the second thing you do is you react to let that go. And you had some time there. The Venturi and the diaphragm pumps don't do that. Tip occlusion starts and it goes immediately to 300. The moment you occlude the tip, you get what you asked for. So there's no safety for error in there. If that happened to be a piece of iris or a piece of posterior lens capsule and you had it set to 300, you got 300. You're going to tear things, you're going to do harm. And so as you learn, having that peristaltic is safer. Okay? Think of tip occlusion like this. You have a straw and you're drinking a strawberry milkshake. And mostly what you're getting is milkshake. It's just coming into your mouth, but in the bottom, there are strawberries, little bits of strawberries. And suddenly a strawberry comes to my straw and occludes the tip. So you're drinking, and then all of a sudden, and you're getting nothing. That's tip occlusion. That's vacuum and flow, and then tip occlusion. When you hit tip occlusion, you now own whatever is occluding the tip. Hopefully it's lens. That's the moment you can turn on your phaco machine. Okay? And so here is a foot pedal in phaco mode. Position 1 gives you irrigation as I push the pedal down. Position 2 engages the pump. I have irrigation and aspiration. There we are in position 2. Fluid is flowing in and we're aspirating. Just continuous in and out, in and out. The chamber is stable. And then when you tip occlude, you'll hear a tone change. The pump is running. When you tip occlude, Don't turn this sound off and don't turn your music up loud because I want to hear that sound. When you tip occlude, you will hear the vacuum. The machine is designed to give you a tone. And the vacuum builds. It goes. As that vacuum builds, now you can go to position 3. That's your phaco. Where young surgeons and residents use too much fluid and too much time is they go to position 3 when there's no tip occlusion. Irrigation, aspiration, I'm drinking the milkshake, I got no strawberry, and then you just turn on the phaco. What am I phacoing? Aqueous, liquid. There's nothing on the tip. There's no occlusion. You should not have gone to position 3. You don't get to turn the machine to phaco where it goes until you hear. You have to hear tip occlusion. You have to hear the vacuum rise. Now you can go ahead. Okay, and so this is what those foot pedals do. This is in phaco mode. Irrigation always. Irrigation aspiration in position 2. Irrigation, aspiration, and phaco in position 3. And aspiration and phaco are linear. The farther you push the foot pedal, the more you get. So if you set the vacuum at 300 and you were only halfway in position 2, you're not getting 300. You get 300 when you're all the way to the end of position 2. So it's linear. The vacuum goes 0, 100, 200, 300. That's what you asked for. And then the phaco you set at 70%, and it's linear. And as you step down, 10, 20, 40, 70% phaco energy. Okay? Here's the most important part we haven't talked about, though. The most important part of the foot pedal, aspiration reversal. Every pedal is different. On this one, it happens to be foot to the side. Sometimes it's toe up. What is aspiration reversal? It's the brake. Instead of aspirating, you blow back. That's what you need to know immediately on that foot pedal. If I grasp the posterior lens capsule or iris, instantly I go to aspiration reversal and I let it go. Because I was on a peristaltic pump, I had some time before the vacuum got bad, and I let it go. So when you teach a person to drive a car and they sit in the driver's seat, the first place you teach them to put their foot is on the brake. That's the safety pedal. When you sit down to a phaco machine, the first question for that foot pedal is, where's aspiration reversal? Where's the brake? And you can't think about it. You just have to know. Just like in your car, I don't think about braking, I just brake. Same thing on your phaco. You set your machine so that you have a stable eye. I don't want an eye that's too soft. I don't want an eye that's too hard, too pressurized. The cornea starts to haze up. And so I want a stable eye. I don't want chamber bounce, and I don't want chamber elevation. I just want a stable eye. Everybody will have different settings. When I start as a one-handed surgeon, I'm generally running about 20 vacuum min, 70 vacuum max. When I go to pulse, when I go to IA, the vacuum increases. 300, 400 sometimes on my pulse settings on vacuum. Okay, and so here, this is the kind of the settings that Ortley and Vision has on their machines. Phaco 1 is when you're starting to groove. Whole lens, I've done my Rexus, I'm getting ready to just go ahead and start. I've got a flow of 20 and a vacuum of 100. That's fine. But now I'm cutting into quadrants or I'm dealing with fragments, pieces. It's getting loose, it's moving. Well, I want more vacuum. I need to hold those pieces better now. But as I increase the vacuum, I have to increase the flow rate with it. because as I pull more fluid out, I need to push more fluid in order to maintain that stable eye. Okay? When you start, you don't need a lot of vacuum. The lens is stable. I need more vacuum when I'm starting to get into cracking, chopping, and fragments, when I need better holding power. And we're going to watch some videos on these. I showed you a hockey picture before. I am a Canadian and I do think in these terms. Vacuum and phaco. This is vacuum. This is phaco. If you try to phaco without tip occlusion, let me just explain to you. If you're on the ice in a hockey game and you're in a fight and you simply start throwing punches, as you move forward with your fist, you also move backwards because you're on ice. There's no ability to have an impact. And so before you get to throw the power, you actually have to grasp and hold something so that the power is delivered efficiently. Please stop phacoing aqueous. Stop running your machine. For example, I'm going to cut a groove. I don't phaco on the back maneuver, right? I grooved, and then I'm going to come back and I'm going to cut another groove. But young surgeons phaco like this. It's a waste of time. Only when the tip is occluded, only when you have vacuum can you turn on the energy. Otherwise, you're just delivering cavitation, bubbles, wasted energy, and trauma. Tip occlusion. Listen for the vacuum. I go into ORs and they've turned the sound on the vacuum off. They put the sound in the machine for a reason. Listen to it. Or I go in and they've got AC/DC rock and roll playing on volume 10. Can't hear the vacuum. I'm fine with music. I love having music in the OR, just at a level that I can still hear that vacuum. And I'm listening when I'm teaching a resident, I'm listening. If you're phacoing without vacuum, I'm going to say something immediately. You're phacoing aqueous. You just wasted energy. If you want to be beating me on time, then stop phacoing aqueous. Efficiency. Tip occlusion is critical. So adjust your needle to tip occlude. If I've got a 45-degree needle, it's sometimes hard to occlude. Turn it. You can turn it to the side. You can turn it to get a wall over here, right? You can move that needle to try to find ways to get better tip occlusion, and listen for that vacuum before you turn that phaco energy on. When you get vacuum, so I've now got, and you to that fragment, you've got vacuum, you have a strawberry in the end of your straw, I've built vacuum, and then all of a sudden you fragment it and it goes up the tube. That strawberry suddenly comes up the straw. You're going to get surge. That is, I have vacuum, it's at 300 because I tip occluded and I've got 300 millimeters of vacuum, and then suddenly I fragment and I've got 300 millimeters of suction pulling everything in immediately. The old machines don't do well with that, and you tend to get chamber bounce because all of a sudden you're pulling at high vacuum. And what happens is, here's the posterior lens capsule, and here's where my fragment is. And I'm fine. But when I suddenly break that fragment and I get 300 millimeters of vacuum, guess who comes to see me? The posterior capsule immediately comes towards that rush that's going up the tube. And that's when, I cut the posterior capsule. That was surge. Chamber collapsed, everything rushed into me. The chamber shallows. The new technology deals with that. The machine senses that and shuts it off, it doesn't allow the surge to happen in the same way. And so again, new machines are more efficient. They're better at cutting. They will shorten your time. They'll mitigate your surge. They'll give you better control over flow rates. And so just understanding your machine and what the pros and the cons of that old free phaco machine that somebody gave you are. Okay. This is one of my favorite papers. This is done by the group in South Korea by Kang Moon. This is absolutely an amazing way to look at what's happening with fluid dynamics. So here's what they're going to do. They're going to take 10 eyes, these are cadavers, and they're going to do phaco. These are normal lenses, cadaver eyes, and they're going to adjust the fluid height of the bottle. Group L is low, group H is high, and they're going to look at where the fluid goes. So here's group L. The bottle is at 50 millimeters. The vacuum is at 80. That took them 117 seconds to fragment the lens, 165 mLs of fluid. Here's the high bottle group. The bottle goes up to 120 millimeters. The vacuum has to increase to deal with it. Their ultrasound time was shortened, but their volume of fluid was increased. You as a cataract surgeon believe you are living in the front third of the eye. You are wrong. Here we go. Green is vitreous. They put contrast material in the phaco fluid so we could image it. So in red is where that fluid is going into the vitreous. Low bottle, and you can see how much fluid from your phaco ended up in the vitreous. Look what happens with the high bottle. Almost 90% of the vitreous you have pushed phaco fluid in. You didn't break the posterior lens capsule. You didn't damage the zonules. It's a healthy vitreous. How on earth am I doing that? You think as a cataract surgeon that as long as I didn't break the posterior capsule, I didn't bother the vitreous. Not true. You did. You shoved irrigation fluid all the way back to the optic nerve. Consequences of that? Fluid in the vitreous. First of all, it's worse opposite your phaco needle. Phaco needle comes in here. That's where it's worst. The more fluid, the longer you're in there, the worse it gets. The higher the bottle, the greater the vacuum, the worse it gets. That was in normal vitreous. Imagine what it does with vitreous that is degenerate, and think of the consequences of the fluid you're pushing back there. Retinal detachments, vitreal prolapse, vitreous contamination, hyalitis, endophthalmitis. We know cataract surgery is not a sterile technique, and you're pushing fluid into the vitreous. And so when you start looking at an animal at 6 weeks post-surgery, and you're trying to get him off his steroids or his non-steroidals, and he keeps having some inflammation, look very carefully at the vitreous. If there are cells in the vitreous and you have a little bit of a low-grade hyalitis and you wonder, how did that happen? This is how it happened. You push fluid in every case into the vitreous, and the more fluid, the more flow, the more force, the farther back it goes. There's another setting on your phaco machine called pulse. Pulse, the machine turns itself on and off according to what you asked, right? And so here we've set 2 pulses per second. Here we've set 4 pulses per second. And so the phaco machine doesn't go, it goes. Why? Because by momentarily turning it off, you did 2 things. You decreased the amount of energy, that's good. And by turning it off, you gave a moment for something to come and tip occlude and me to build vacuum. If you start getting fragments and you just go, if you're just the whole time, you keep knocking those fragments away. But by going, you give a moment's pause to allow the vacuum to get a hold of that fragment and then let the energy be delivered. So the power pulse burst mode settings decreases overall power delivery, can give you a better, deeper chamber because you can get better vacuum. At that point, I want high vacuum. If I've gone to pulse, I've either got fragments or I'm trying to tear things, walls down, my vacuum goes up. Okay. And so here's what continuous linear phaco does. You set it at 70%, you step on the foot pedal, it's continuous up to 70%, and then it just keeps going at 70%. In pulse mode, you are also linear. Okay, and so I'm going to start, but I'm bursting every 2 seconds, and I'm linear up to 70%, and then I just stay at my preset. In burst mode, in some machines, you get 70% immediately, and the farther you step, the closer you get to continuous. And so burst mode is right? So you have to understand your machine. Am I in pulse? Am I in burst? And what's the difference between how that foot pedal is going to control them? Okay, and so different machines do different things. So we're on linear phaco, continuous. As that fragment begins to break away, I'm going to change to pulse. Watch now. See how that vacuum went? It went from 70 to about 350 on the vacuum, and it pulled those fragments in, and look at its holding power. So I have more vacuum, better holding power, and even on your foot pedal, you should still be pulsing. So just because you're on pulse, you don't step on the foot pedal, go, you still can go as you need it. Controlling your foot pedal, remembering it's linear. I got 0 to 70% on my preset. I've got much higher vacuum. I can begin to pull those things in. Okay. Very briefly, I think this is actually Doc Jack's video. I don't use Trypan Blue, but I'm just using it to show you. We're going to now run through just a quick nuts and bolts. Capsulorhexis, just showing you this is a continuous curvilinear. You need to be able to tear in both directions. I don't use Trypan Blue, but you're welcome to if you want to. Okay, Vanna scissors, Utrata forceps, lots of different ways to do your rhexis. Go back to Eisner's. Shearing forces, not ripping forces, are what we're after. The Ortley has an interesting feature on it, which is the capsule diathermy unit. This is a horse. This is set on the capsule setting. I don't know if this is my video or Dr. Gilger's video. I can't honestly remember, but either one of us. And we're doing the capsulorhexis using the diathermy setting, which I love for horses. And I know Dr. Spiess, when he was doing surgery at Zurich, used this in small animals as well. It's a capsulorhexis feature only on the Ortley phaco machine, as far as I know. So we basically just did a little bit of cautery to mark out where I want that continuous capsulorhexis. We're going to switch to equine Utrata forceps, which are also Anvisions, slipping in, and watch what basically this has done for my capsule. It's pre-perforated. It's a wonderful little tool outcome, and you have a perfect circle. Okay, and so our goal is a nice controlled circular capsulorhexis, whether that's Vanna scissors, whether that's Utrata forceps, whether it's diathermy, whatever works for you. The key is to avoid the Q sign. The Q sign is where you tried to make a circle, but you left a tear. And here's how that happens. You make your initial cut, and your goal is that, a nice complete circle. But instead what happened is the radius of curvature spiraled in on you. and you left a tail, and that tail's going to do that. In order to avoid that, you always have to work on the circle that has the largest radius. And so I'm going to tear in a counterclockwise direction, and I'm going to stop right there because I can see this is spiraling in. And I've been going counterclockwise. I'm going to stop. I'm going to regrasp there, and I'm going to tear clockwise. And so as a learning surgeon, please learn how to tear both clockwise and counterclockwise, because you're going to need to be able to tear in both directions. And you do that in order to get a controlled circular tear. Hydrodissection. Do I hydrodissect? Not if I'm doing one-handed surgery. I do not want that lens moving, and I absolutely would discourage hydrodissection if you're doing one-handed surgery. I hydrodissect for two-handed surgery, or if I'm going to put a capsule tension ring in. This is a hydrodissection in a human. Look at the fluid wave. Beautiful. I promise you, you will never see that lat well in a dog. It just won't be that beautiful. But here's a case where I would hydrodissect. Oh, sorry. I thought I was coming to a different video. We'll get it later. Hydrodissection is better for two-handed technique because it makes the lens movable. I can spin it. I can do things with it. It's good for divide and conquers and chip and flips. It's good if you're putting a capsule tension ring in. It's less desirable for one-handed because I don't want the lens spinning when I only have one instrument in the eye. Here's the video I thought. So this is an unstable lens. I've done a capsulorhexis. I'm going to hydrodissect. And then I'm going to put a capsule tension ring in before I phaco. In order to put that tension ring in, I need to hydrodissect first. Okay, this is an old injector. This was actually early cases, the human injector, and so the capsule tension ring sticks out the end. It normally doesn't do that in the canine injectors. Okay, but because we've hydrodissected, we've created capacity now to go ahead and put that capsule tension ring in before I phaco. So I go under that capsule, I start to inject. You'll see that capsule tension ring appear down here at 6 o'clock. You'll see it come over here. Okay, and so hydrodissection has allowed me the ability to put that capsule tension ring in. Hydrodissection brings with it the concern, if you are too forceful, could you blow out the posterior capsule? Yes, you could. And so it's done carefully, and it's done specifically when you need a mobile lens or you need space. Surgeons, you need to be adaptable. I said this at the beginning, and you need to know more than one technique. So let's look at the techniques, one-handed versus two-handed. The terms that get thrown about, people say, oh, I do divide and conquer. I do chip and flip. I do phaco chop. They're all maneuvers, and you actually should be able to do every one of those maneuvers and use them when indicated. You need to know how to do it one versus two-handed. And a lot of young surgeons think, oh, two-handed is so much better. So here is a 2019 study in humans comparing coaxial one-handed versus coaxial two-handed with a 2.4 millimeter incision. They have 105 eyes in both groups, 105 eyes one-handed, 105 eyes two-handed. Here's the conclusions. Both one and two-handed were effective and safe. However, one-handed had the advantage of less trauma to the cornea, less endothelial loss, and better early clinical outcomes than two-handed. It makes sense. If you don't need the second instrument, it adds time, it adds trauma, and when there's two instruments in an eye, there's twice as much chance one of them is going to do something you didn't want it to do. So look at the numbers. One-handed versus two-handed. Total ultrasound time in seconds, 27 versus 23. Statistically not significant. Average power, statistically not significant. Fluid volume usage, not statistically significant. Total surgical time, not statistically significant. And so when you need two-handed, it's wonderful. Subluxated, luxated, old animals, hard lenses, absolutely it's wonderful. It has its place. But to simply knee-jerk reaction to two-handed on every single patient is unnecessary, and it adds complications. It adds time, it adds fluid, it adds sutures, it adds a second instrument, and it's unnecessary. Okay? My opinion. Somebody will argue with me and be adamant. That's cool. Everybody's entitled to an opinion. So one-handed. What if I'm going to do a one-handed technique? How do I do that?
David.
Yeah, please, Ingrid.
So we have one question. The surgeon struggles with the mobilizing the first fragment after making the groove.
Lovely.
Could you give us some tips how to mobilize the first fragment?
Absolutely. It's sort of like I had a plant. We have 700 in the audience, and I must have planted, because that's exactly the question we want for the next couple of slides, because it's perfect. Thank you for the question. Thank you, Ingrid. Here, we're going to look how to do that. How do we do that first fragment? So our goal as one-handed is to sculpt a bowl and have that bowl collapse, or to deal with using suture lines to carve out a third of that lens, cracking the bowl, collapsing the bowl. So let's watch a couple of videos on how to deal with that first fragment. Before we do that, though, I want you to remember this. You think the zonules go from the equator of the lens to the tip of the ciliary processes. They do not. They go from the equator of the lens to the ciliary processes. They enmesh and envelop the ciliary processes. They run through the valleys, and they go all the way back to the ora serrata. Here's how I want you to think about it. Look at the silk on this corn. It runs the full length in between all the little kernels of corn. This is a ciliary epithelial cell. It looks just like that kernel of corn. They look the same. These are zonules, all running in between, and they're going from the equator of the lens right there all the way back to that, which is the ora serrata. These are the hills and valleys of the pars placata. And you need to understand this. You pull on the lens, you pull on the zonules. You pull on the zonules, you pull on the ora serrata. If you pull on the ora serrata, you're pulling on the retina. And it may lead to retinal detachments and retinal tears. And again, the surgeon has to own the complication. Too many times we get a dog post-surgery that had a retinal detachment, and they go, oh, it's a Bichon, it's a Boston. And you blame the dog. The dog didn't do the surgery. You did the surgery. You own the complication. You should have taken steps to mitigate the risk factor and maneuver that lens as little as possible. When you're doing the rhexis, when you're doing the phaco, whether it's one-handed or two-handed, stability is key. So let's go to the question. You're exactly right. The first piece is the most difficult. And so here we've got a pie, we have a lasagna. When my mother serves pie or lasagna, she always takes the first piece for herself. She eats last, but she always takes the first piece. Why? Because the first piece is hard to get it out, and it doesn't look as pretty sometimes. There's less room to maneuver, and so that first piece of pie, oh, I'm not going to give that to the guest. I want to give them the beautiful, perfect piece of pie, because we recognize it's hard to get the first piece out. But once you get the first piece out, every other piece comes out so easily. So look at the suture lines. Got one suture line here and one over here, and we're working on a third. We're going to take down that suture line. Look at that. 1/3 of the lens is gone. I'm on pulse, and I use the suture lines to take that first piece. Now I'm going to crack along the last suture line, and I have 2 pieces. Okay, and so if we go back to that video, we have suture line there and a suture line here. We're going to work down those suture lines, and we're going to take 1/3 out. That creates space. Right down the suture line, and perfect. Easy in a diabetic. It's already cracked along the suture lines. It's already intumescent. Now we're going to use the next suture line right there, and we're just going to split it into a piece, rotate it over. This is an easy one. What if it won't crack? What if I can't get that third out? So I've carved my bowl. Well, you've carved this bowl thinner and deeper. Change and increase your suction and pull the wall in. I'm going to reach with my suction now, tip occlusion, don't fragment, just pull. So I've carved that bowl, and I reached up to the top of that bowl, and I used the suction like a hand to pull it towards me, right? Using that suction, I'm now running at 350 or 400 on my vacuum. Okay, and I'm on pulse setting, but I used the suction. I carve, if I can't crack it on the suture lines, so I can't pull that third in, then I'm going to make the bowl as thin as I can, and then I'm going to ask the wall to cave in. And the last one, which Ingrid tells me I shouldn't do, and she's right. She told me I shouldn't do this, and whenever Ingrid tells me there's something wrong with what I'm doing and I'll have a complication, I always say the same thing. I've never had that complication. And then I go home and I have it right away. It's as if she just manages to bring it to truth. I'm going to flip the whole bowl right there. I push down and I flip the whole bowl. Now I have high suction and I pull it over. So I carved that bowl, and then I went to the near part and I pushed on it and I flipped it all the way over in the bag. So I'm now looking at the posterior capsule. Watch it one more time. Push, flip, suction, and pull it over. And Ingrid said to me one day, we've done this course for so many years, she said, you're going to break the posterior lens capsule. And I went, I've never broken the posterior lens capsule. The very next one I did this on, I broke the posterior lens capsule. The maneuver is a very dangerous maneuver. The flipping is not dangerous, but if you only flip it halfway, it's now sitting up like that, and it's pushing on the posterior capsule. Or if you flip it and it rocks back, it tears the posterior lens capsule. So that's the most dangerous maneuver in a one hand. My goal, use the suture lines, crack down the suture lines, take that piece out. That first piece of pie comes out, and then you can start spinning and work on the other suture line. Or try to use your suction to pull the wall down. Use it for what it's designed to. Go to pulse, go to high vacuum, and tear the wall down. If you want to do two-handed,
David, there's another question. Going back to the capsulorhexis, the surgeon asks, do we have a standardized size, or does it depend on the case, how big the capsulorhexis will be?
It depends on the IOL. And so the capsulorhexis should not be bigger than the IOL. It should just overlap the edge of the IOL. So if your intraocular lens is 6 millimeters, you want about a 5 millimeter capsulorhexis, okay? You want it to just be on the edge of the optic. If you let it be bigger than the optic, the anterior and posterior capsules can come together and you can get lens regrowth. Your best thing is to start small and make it bigger later. So you can make a small capsulorhexis, do all your phaco, and then you get great view because now the cataract is gone, and you can make a little cut and you can tear the rhexis bigger, okay? But it should be slightly smaller than the optic. It should be central and slightly smaller than the optic. two-handed for hard lenses, unstable lenses, and it can help to shorten your surgical time. You're going to use a side port incision, probably about a 1 millimeter keratome. I do that after the phaco needle is in. That's how I do it. Okay, so here we go. We've made the incision. We've done the capsulorhexis. My phaco needle is in. Here's my knife. Watch it push and step on the irrigation pedal. There, push back against it. And now I have my side port. It's about 90 degrees. And then whatever instrument you're going to be using, okay, you're going to put in through that side port incision. Okay, what do I do with that second instrument? There are choppers, there are crackers, there are manipulators. Christy Warren has some, Federico Maggio. There are some nice presentations on different manipulators. I'll show you the one I use most often, which actually looks somewhat like this, but has a slightly bigger paddle on the end of it. You can use it to cut, which is a phaco chop. You can use it to crack, which is a divide and conquer. Those are the two most common maneuvers. I'm going to show you both. There's my instrument I use most often. It's basically looks almost like a tennis racket or a golf club. It's flat on the end, and I can do both chop and crack with it. I'm a right-handed surgeon, and so the phaco is in my right hand here. My chopper, my cracker is in my left hand, and I'm going to carve a groove. Then I'm going to go deep into that groove and I'm going to crack. And that's the key, deep in that groove. Okay, down here and push them away from each other. This is not correct because all you're doing is moving the upper part of the lens. The lower part is a hinge. It will pinch and tear the posterior capsule. So you need a deep groove and then you push straight apart. So here we go. This is a reasonably soft lens. I'm going to cut a groove and I'm going to do two maneuvers on this. I'm going to do a divide and conquer, and then I'm going to do a phaco chop on the same lens with the same instrument. Here's the side port incision coming in. Second instrument comes in. Watch the hand motion, watch the position. Goes down into the groove and watch the direction of motion. Okay, that's a chop, that's a crack. I rotate it. I'm going to carve another groove. And I'm going to do the same thing, and I'm going to crack it. Now I'm going to show you with a fragment of phaco chop maneuver right there. And I'll do another phaco chop right there. The phaco chop is when I hold the lens, vacuum to it, and then use the second instrument to cut towards the needle. So one is cutting a groove and cracking it, and the other one is holding the piece and then dragging the instrument towards the piece to crack it in half. Divide and conquer, phaco chop, same eye, same instrument. Both maneuvers helped to move this lens along. Here's an incorrect divide and conquer. The hands are moving in the wrong direction, first of all, and secondly, they're way too high. We spun that lens, we created a hinge at the bottom of it. You may well already have torn that posterior capsule, and you've only just begun, and you don't know you did it. And all of a sudden, that lens in the middle of your surgery will disappear into the vitreous, and you wonder why. Because at that early stage, you tore the posterior lens capsule from an incorrect maneuver. Okay? So two-handed for phaco chops, two-handed for divide and conquer, two-handed for unstable lenses. So I'm going to divide my unstable lenses into those of less than 120 and those of more than 120 degrees instability. So on one like this, I'm going to try to do a two-handed phaco with a capsule tension ring. It helps to have a second instrument for the capsulorhexis. This is a Jack Russell Terrier. This lens is about 100 and 120 degrees unstable. The other eye is lost. It had a lens luxation and glaucoma. Look how loose that lens is. Remember what the zonules are doing. So we're going to do a two-hand capsulorhexis. I'm using the duet. I have forceps in my right and scissors in my left hand. And so I'm doing, now I've switched. Now the scissors are in my right hand. I'm trying to not pull and tear. I'm trying to stabilize and cut that capsule to minimize how, okay, it stabilizes that lens. It decreases zonule tension. It prevents capsule phimosis or capsule shrinkage. It mitigates PCO or posterior capsule opacity. Okay. The size of the ring should match the size of the lens you think you're going to put in. And so if you are putting in a 12.5 millimeter or 12 millimeter lens, it's a 12.5 millimeter capsule tension ring. If you're putting a 14, so they match. So know what size IOL I'm going to put in. That'll help you to decide what size capsule tension ring to pick. Okay. And we saw this. We're not going to watch this video again, but this was the unstable lens where I showed you pre-placing and then going ahead and doing your phaco. Okay. So less than 120 degrees, I would do your rhexis as carefully as possible, minimize any zonule tension, maybe do it with scissors, or you could do it with the diathermy unit. Hydrodissect, pre-place your tension ring if you so want, and then I would do a two-handed technique to take that lens out to give you some counter pressures. So again, as little movement of that lens and that capsule as possible. If it's more than 120 degrees, you're not going to save the bag, right? So if it's like this, capsule tension ring isn't going to save you. So here's one that's 240 degrees unstable. We're going to phaco this as best we can in the bag. We're using the second instrument to give us some counter pressure against that capsule, try to help keep it. We're also going to use that second instrument to crack and to chop, again, to try to be as efficient as we can. And then it's 240 degrees unstable, so the whole bag comes out. And I'm actually going to use the second instrument here to help me with the zonules. So I'm going to use that second instrument to break those zonules. And I'm going to pull the whole bag out. Okay. Now you have a decision to make. You can leave him as an aphac, or you have to suture a lens. What about the total luxation?
Hey, David.
These Jack Russell. Yep.
Another question. Hydrodissection. Do you have any tips? There's a surgeon is facing challenges to get the lens free, and asking what cannula diameter are we using, and also is there any role for hydrodelineation?
I don't do hydrodelineation, which is separating a little different separation zone. I don't do hydrodelineation. For hydrodissection, I'm using a 23 gauge cannula. To me, I never see the fluid wave in a dog the way and if somebody else sees it, that's wonderful. But for me, I simply go underneath that capsule, go out and I inject, and I do it in a couple of different locations. And if you've done it right, the lens should begin to feel like it wants to spin on you. Okay, you'll see that happening with as you phaco. Even if you're doing one-handed, that phaco fluid will hydrodissect somewhat, and the lens starts to spin on you sometimes. I don't have any other greater tips than that. Ingrid, you have comments? Do you hydrodissect?
Just for like, if I have a subluxated lens, I don't hydrodissect because I'm a one-handed surgeon typically.
Yeah. Yeah.
David, there was another question regarding the capsule tension ring.
Yep.
Has anyone used a too small one or a too large one? And could it make problems? How do you measure it? Are there complications? Could you comment on those, please?
So, yeah, so we have a paper that was published a fair bit ago, just looking at phaco. We just divided them into two groups. Half of them got a capsule tension ring and half of them didn't, within the same dog. And so we randomized the eyes and we just put capsule tension rings in. There were absolutely zero complications. I think we had 46 or 50 eyes, something like that. There were zero complications with the tension ring, so it had no negative effect. Having said that, If you were to put in one that was too big, yeah, you certainly could rupture a capsule. How do I know? I have a really bad answer, and it's I've just done enough. I know what size IOL I'm going to do. So the average dog for me gets a 13 millimeter IOL. A great big intumescent bag like a diabetic Labrador or a diabetic Springer Spaniel is going to get a 14, and a little Jack Russell Terrier is going to get a 12. That's kind of where we are in terms of lens sizes, and based on my lens pick, that tells me what size capsule tension ring I'm going to pick. If you're nervous to put the tension ring before the phaco, and I get that, that's scary, then put the capsule tension ring after the phaco. Take the lens. It's easier and safer to do it at that stage. It just doesn't give you the counter pressure while you're doing the phaco. But you certainly can put it in after the phaco. And Ingrid, you put capsule tension rings in almost everything, right?
It's my goal for every dog. I just see the advantages, and I will go for the larger capsule tension ring because it will typically fold over. So I haven't seen any complications with a too big capsule tension ring.
And you generally put them in after you've done your phaco and cortical aspiration, but before the IOL, right?
Yeah, typically. I just do it different in subluxated lenses, but in the typical phaco case, I will do it after irrigation aspiration.
Yeah. So what if the lens is totally luxated? Not subluxated, but it's luxated, anterior or posterior. There's a study from Sue Manning and the group out in the UK that was presented as an abstract at the meeting, never has made it quite into publication other than the abstract. But they took dogs with lens instabilities and they divided them in to two groups. Those that got intracapsular lens extraction, so big incision, deliver the whole lens, and those that they did phaco. Didn't matter if it was anterior, posterior, they randomized these cases. Both groups had pressure issues. So glaucoma is a concern regardless. But the group where they did intracapsular had a 28% retinal detachment risk, and the group they did phaco had a 6% retinal detachment risk. And so I'm always going to try to phaco if at all possible. If you have a lens luxation it's a non-cataractous lens in a 6-year-old Jack Russell, that lens can be phacoed. Can I phaco a complete hypermature cataract in a 12-year-old dog that's completely luxated? No, probably not. The lens is too hard. But if you have a lens that's reasonably soft, not terribly hard, you can phaco posterior and anterior. And in doing so, by following the rules, our goal was small incision surgery. Phaco achieves that. Intracapsular does not. That's where the retinal detachment risk comes from. So here's a total anterior lens luxation. This is a Jack Russell. Made an incision. I'm putting visco under the lens. I'm going to make an entry into the equator of the lens. I'm not doing a rhexis. I'm simply making an entry for the phaco needle. That's it. That's all I'm going to do for the capsule. And then I'm going to take the phaco needle and embed the lens. Now I'm going to put a second instrument in. And that second instrument can go under that lens if need be to help support. It can give you some counter pressure. And I'm going to do the phaco in the bag. This is non-cataractous, but it's a complete lens luxation. When I'm all done, I will pull the entire capsule out. There's a little bit of cortex right there that escaped. I'm coming in with the vitrector, and I'm using the guillotine vitrector, and I'm going to clean up that last little fragment that fell out of the bag, and I'm going to clean any vitreous that's in the anterior chamber with that. And my retinal detachment risk is 6% based on Sue Manning's study. I still have a glaucoma risk. I recognize that, so I'm going to deal with the glaucoma by doing endolaser. Okay, and so when the vitrectomy is done, I'm going to slip in with the endolaser. There's the ciliary processes. I'm looking at the heads and the tails. I can see all the way back to the aura. I'm going to endolaser this patient to mitigate the glaucoma risk in this particular dog. So I recognize the risk of glaucoma and retinal detachment. I minimized the retinal detachment by doing phaco instead of intercap, and I minimized and managed the glaucoma with an endolaser. This is Dr. Gilger's video. This lens is completely luxated in its posterior. You can still phaco it. We're putting a posterior segment. This happens to be an O'Malley lens so that we can visualize the lens all the way back at the retina. We're back with viscoelastic. We're going to go under that lens and we're going to backfill it. And in doing so, we're going to float the lens all the way up on a bed of viscoelastic right into the anterior chamber. I would use a high viscosity visco for this. Now the lens is sitting in the anterior chamber. And it's on a nice bed of visco with two instruments, two-handed technique. Going to come in and we're going to phaco that in the anterior chamber just like the last case. Again, minimizing the posterior segment risks for retinal detachment, minimizing the size of my incision, following the basic principles of small incision surgery. Okay. Can we put lenses in these dogs? Yep.
Positive vitreous pressure, how do you overcome it?
Positive vitreous, I'm not sure I'm understanding the question.
I guess if the vitreous is pressing from below, so how can you handle a vitreous that is just expanding? Maybe it's expanding.
It's like a vitreous expanding syndrome. So I don't see that anymore. It used to be 20 years ago. I don't know why I don't see it. But here's the thing to remember. The more fluid you're pushing, remember Kang Moon's paper. Remember where that fluid is going. If you're using large volumes, if you're using 300-400 mLs of fluid, you're pushing substantial amounts of fluid into the vitreous and you're overhydrating it and it will begin to push forward. Okay, so the first thing is minimize amount of irrigation by being efficient and utilizing limited time, limited energy, limited fluids. That's the first thing. Next thing, if you're seeing vitreous expansion, the number one reason I see it is external pressure on the globe. It's your eyelid speculum, it's your drape. Something is pushing from the outside. So many times the drape has migrated towards the surgeon during the surgery. As you continue to move, you bump that drape and it begins to move, and now it's pushing on the lower eyelid, or the lid speculum is pushing, and that external pressure is squeezing the eye, and the logical place is for the vitreous to move forward. Okay, so those are the things I see most often is excessive hydration with fluids and external pressure. If you break the posterior lens capsule, the biggest mistake people make is they reach in to the vitreous to try to get things with coaxial flow. So you go in with your phaco needle or you go in with your vitrector using coaxial irrigation aspiration through the same port. You're hydrating the vitreous. Terrible maneuver. You never irrigate in the vitreous. And so if you've broken the posterior capsule, and this gets into a whole slew of complications that Ingrid and I talk about in the ANVISION course, but that's where you go to bimanual. You pull the infusion line off the phaco or vitrectomy, and you put it on a second port in the anterior chamber. You can come down into the vitreous with your guillotine vitrector. You can come down with your aspiration, but your irrigation is always up in that anterior chamber, never down into that vitreous. Those are my best comments in terms of trying to deal with vitreous expansion. But I'll be frank, I haven't seen vitreous expansion in ages. I used to, and I think because we used to be inefficient. I had old phaco machines. We used lots of fluids, and we didn't know why we were seeing it. I think Kang Moon tells us why we're seeing it. We're pushing fluid into the posterior segment, into the vitreous.
Okay, There's
Yep.
another question for the luxated lenses. You talked about the endo laser,
Yep.
but something else is the retinopexy.
Yep.
Do you think, what's your opinion on that?
So retinopexy, I would never do a transscleral retinopexy. That's the first thing. I do prophylactic retinopexies, and I would either do them with the indirect headset and a condensing lens through an IOL, or I would do them with the endolaser probe. Dr. Dina Lee Bras in Puerto Rico is the endolaser queen. She was our resident phenomenal surgeon, and Dina Lee does them with the endo probe. So she makes a small window in the posterior capsule and goes in and does a peripheral pexy 360 degrees near the aura. I don't find myself very comfortable with that. And so for me, if you are concerned about detachments, I would put in an IOL. I would pick an IOL that was not one of the ones with all those concentric rings, which do great at focusing to the posterior pole, but you can't laser peripherally. And so you're looking for an IOL that just has a uniform cover to it, uniform shape, no concentric rings. Put that IOL in, finish your surgery, suture your incision, and then before the dog wakes up, I put on my indirect headset, I take my condensing lens, and I do a 360 pexy around the periphery. Okay. So again, we're getting into the complication lectures, which is not really this lecture, which is more phacodynamics, but I'm happy to answer those questions. But I have videos and all of those in the courses we do for ANVision that go through all of that and how we do it. All of that is in there. If you have a lens capsule that's completely luxated or more than 120 and you have to pull the capsule out, you either have an aphac or you're going to have to suture a lens. This is a cadaver video just to kind of give you an idea of how you suture lenses. It's beyond the scope of this particular talk. We're coming up on 2 hours, but this is 9-0 nylon. This is a cadaver dog. The lens has been removed. That's 9-0 nylon in a 30 gauge needle. Up the lumen of the needle, and then the needle is simply poked in through the sclera into the ciliary sulcus. We're going to reach in and grab the loop of suture. We're going to pull the needle back out. So I have a loop of suture, 9-0 non-absorbable nylon. We're going to do a second suture 180 degrees over from that. And you can do a third. You can do a 3-point fixation if you need. So again, that 9-0 up to 30 gauge needle, push it in, reach in, grab the loop, pull the loop out. We're then going to use those loops to do what's called a cow, C-O-W, cow, like moo, hitch technique. So there's no knots that are going to be needed. This is the acrylic foldable suture lens. We're going to grab with a lens dialer, we're going to pull that loop through the dialing hole, and we're simply going to loop it around the haptic. So we don't need to tie it. We can just lasso it. Okay, and so that's one suture attached. And you can do this with the acrylic lenses as well. You just need a larger incision. With the PMMA lenses, you just need a larger incision. We're going to attach the second loop. We're just putting that around the acrylic haptic. This is a foldable lens. I like that because I can get it in through a smaller incision. You cannot use an injector because the sutures are in your way. So we're going to make the incision about 4 millimeters. We're going to fold that lens in our forceps. We're going to slip the lens through. Let it unfold. And then we're just going to tuck both haptics into the ciliary sulcus, maneuvering that lens into position. Take your sutures that are attached to the haptic and snug them up. Remember, this is a cadaver. Again, just pulling that into position, tucking that haptic into the ciliary sulcus, center that lens. And then I close my incision, and then I tighten, center that lens, and then I tie these two to the sclera, 2 or 3 point fixation, up to you. So there's the corneal incision closed, and then we simply attach under the conjunctiva, under a little conjunctival window. We're going to suture that right to the sclera. And those are sutured lenses. Those are not acrylics. Those are both PMMAs. This one is 2 years post-op, and this one's 24 hours post-op. You can see just a little bit of blood from the suture pass technique. Yes, Ingrid?
One of the attendants asked for the evidence of the benefit of the sutured IOL. Can you comment on that, please?
The benefit?
Yep.
The benefit is simply aphakic 14 diopters hyperopic versus pseudophakic and emmetropic. It's simply focus. And so an aphakic dog is 14 diopters hyperopic. The world is somewhat like a Pablo Picasso painting. The easiest way to show you the difference is compare, well, the dog that showed me the difference, I had a dog that had an IOL on one side. It was a German Shepherd, and it was an aphake on the other side. And so we would patch one eye at a time and let the dog do what it wanted to do. When I let the dog use the pseudophakic emmetropic eye, it was a normal dog. I couldn't tell the difference. It chased balls, it ran up and down the hallways, it went around the corners. It was a very happy, confident German Shepherd. When I covered that eye and I let the dog use the aphakic only eye, the dog bumped into nothing. But it was slow, it was hesitant, it kept its nose down, it came very close to things before it went around them, it didn't chase sticks and balls. It's not blind, it's just 14 diopters farsighted. That's the only difference. There's no value to the sutured IOL other than that. There's also a risk to the sutured IOL. You have to weigh your skill as a surgeon, the benefit to the dog, the owner's desire, and who is the dog. If it's a 15-year-old dog that sleeps 23 hours a day, who cares? If it's a 4-year-old Jack Russell Terrier, and that's the only eye it has because it's lost the other one, and that's a discussion with the owner. Here's what the dog will be if I leave it aphakic, and here's what the dog will be if I make it pseudophakic, knowing that I have to put sutures in, I have to pass needles, and there's a small risk to doing that. Of all the surgeries I do, there's only one surgery, only one, that makes my blood pressure go up. There's only one surgery that makes my sphincter constrict, and that's this, sutured lenses. It's the only surgery that I still go, benefit risk. What do I want to do? It's a decision you have to make in consultation with the owner, the activity level of the dog, your skill as a surgeon. You have a vitrector on your machine. If you need it, use it. This is a coaxial vitrector, so irrigation, aspiration are in the same hole, okay? And I'm in the anterior chamber. I'm not worried about the vitreous. This is a bimanual vitrectomy, so I have irrigation coming in here, and I have aspiration here because I'm going down into the vitreous. I'm pulling some vitreous and some fragments, and I do not wish to irrigate down into that posterior segment. Okay, so coaxial versus bimanual on your vitrectomy. Cortical aspiration, critical part of the procedure. Human IA handpieces for cortical aspiration are 0.3 millimeters. They're too small for dogs. You need at least a 0.5 or a 0.7. You will not pull dog cortex comfortably through a 0.3. Having a curve of some sort, like a Binkhorst, would be helpful. And again, you can see we've got a variety of choices for your IA hand pieces, but you basically are looking at something perhaps like this. There's a Binkhorst J hook, 0.5 millimeter opening for dealing with that cortex. Always remove the near cortex first, and then go and get the distal cortex. There's always more cortex than you think. Sometimes if you've done two-handed technique, you can do this as a human, but you can do bimanual. This is irrigation on the left, aspiration on the right, taking the cortex, and then they will switch the instruments. Makes it easier to get the subincisional cortex. We're switching so we can get the subincisional cortex. Okay, that's why you had that J hook, was to try to get under and get that subincisional cortex. Okay, leaving cortical material, it will resorb, but there is a study in rabbits that was done 2012 that suggested bacteria like cortex more than they like nucleus, and leaving cortex increased in rabbits, increased the risk for endophthalmitis. So get what you can. I'm not a big capsule vacuumer. Some people like to vacuum the capsule. I'm not a big person to vacuum capsules, but there's what it looks like. There is a setting that is capsule vacuum. It's a lower vacuum setting, and you're basically trying to vacuum any residual cells. If you don't like to vacuum the capsule, there are instruments. This is a Whitman-Shepherd capsule polisher, and you can use that to pull cortex and to kind of tease any residual epithelial cells off and then irrigate, aspirate them out. IOL insertion, obviously our goal was emetropia, right? That's an IOL design that would be perfect if you had to do a transpupillary retinal laser. That will allow you to focus out to the periphery, which those concentric ring IOLs will not. Remove the viscoelastic? Sure, if you need to. If you need it for something, leave it. Can I leave the viscoelastic? I left the viscoelastic for years and had little to no problems. For 1 year, I put the visco in both eyes. I took it out of one and I left it in the other. Did I get any more postoperative hyper? Nothing. Had no difference in the incidence of postoperative hypertension, had no differences in terms of complications. I did it to prove one person who said, oh, if you leave it in, you have terrible POH. And they studied with us for a year. I said, sure, let's do the study. Didn't make any difference. Having said that, I take it out if I don't need it. Why would I leave it? I needed to tamponade a little bit of oozing from the iris. I needed to tamponade a little bit of posterior vitreous expansion. If you need it, by all means, you can leave it. But if you don't need it, take it out. There's what you want them to look like. 2 years, these are both PMMAs. That's what I'm talking about as an IOL that would not be helpful to do a retinopexy. Don't put that IOL in a Jack Russell. Don't put that IOL in a breed like why did it just leave me? A Boston Terrier or a Bichon, where you think you might have a higher risk for retinal detachment, because lasering through this is not easy. But those are both 2-year post-ops. That's what you want them to look alike. Completely different lectures, and I'm not going to get into it. This is the stuff we talk about in the ANVISION course. That was great. There's all the stuff that works, but look at all the preoperative complications you have to face, from microphakias, lens-induced uveitis, elevated pressures pre-op. Look at all the intraoperative complications. Pupils constricting. What if I tore the capsule? What if I tore the posterior capsule? What if the lens fell into the vitreous? What if there's bleeding? These are all complication lectures. What about post-op complications? Post-op uveitis, endophthalmitis, POH, glaucoma, capsule fibrosis. Not this lecture. Great topics. Love to talk about them. We love to teach. We love to have discussions. But it's my favorite surgery to do, but there's all sorts of obstacles. And as I said, you have to be adaptable. Your goal is to get from destination to endpoint. There are going to be obstacles in your way. We are the older surgeons, and so things are changing. There's me, there's Dr. Al Gower. She looks better than I do, but we're the old surgeons. Technology is changing, right? Phaco's changing. We have torsional phacos now, not just stroke length back and forth, but we have linear or forward longitudinal, and then we have rotational phaco. And I'm not going to go into all of this, but we've got femtosecond lasers, right? And so you can look up femtosecond lasers on the internet and watch how that is progressing in terms of cataract surgery. And so there's the next generation of residents, programming computers and machines that maybe do that for us. Different lecture. Last thing, always remember you are unique, just like everybody else. There's 700 people on this lecture, 700 opinions. In fact, there's 700 people, there's probably 800 opinions on this lecture. They're all valid. They all deserve to be listened to. You can learn from everybody, and I don't care if you've been doing it for 30 years. You can always learn. I learn something every time we do a course. I learn something from every good question that is asked. Okay. Lastly, we have Sir Harold Ridley to thank for this. That is Sir Harold Ridley being knighted. Sir Harold Ridley is the pioneer for the current generation of PMMA IOLs that we have been using before the acrylics came along. And so thanks to the pioneers of Harold Ridley, Charles Kelman that came before us. I'm at an end point. We'll let Ingrid, if there are any questions. Before I finish, though, thanks to all of you for joining us. Thanks to AnVision and thanks to Zoom for allowing us in this time of COVID to still come together and to share lectures and continuing education. I hope all of you are safe. I hope all of you are healthy. I hope all of you are able to find ways to get vaccinated or to keep your family safe in this time of COVID. And most importantly, my thoughts go to all our friends and all our colleagues in the Middle East who are dealing with horrible situations, be you Israeli or Arab. You are human beings, you are people, you are colleagues, and science and this should bring us closer together. And so I keep all of you in my thoughts and prayers. I hope all of you are safe. I have colleagues and friends on both sides of that, and I cherish all of you. So please stay safe, keep your family safe. So Ingrid, questions?
Well, David, there's some questions that are just not for this webinar that we're going to have to cover in another webinar. And they're like special things like how cold should the infusion fluids be and all that. So I'll just go back to two more questions, which would be, what is the visco that you leave in? What type are you leaving in? Is there any special visco that you can leave on and that you cannot leave in?
That's a great question. And so I've been doing this long enough. I've used every visco that's out there. And so the cheap old viscos, HPMC, hydroxypropylmethylcellulose, I don't think any of us are using anymore. It was made from trees. I try not to leave trees in eyes. I consider those to be foreign bodies, and so I don't use HPMC. So we're typically using sodium hyaluronate, chondroitin sulfate, those sorts of viscos. Most of us are using sodium hyaluronate, and the difference is the viscosity of those. And so they come in different levels of viscosity, 1.2, 2%. And so we've got your everyday viscoelastic, which might be your 1.2%, depends on the company as to who you're buying from, what their concentration is. And then if you need a high viscosity, so I got to float the lens, I need something that's got more capability of lifting or pushing. That's when you start reaching for the high viscosities. I would not leave the high viscosities in there unless you have to. The low viscosities, the 1.2s, I'm okay. When I leave high viscosity, the one place I leave that is when I do endolaser. And so when I'm doing the endolaser, I go into the ciliary sulcus with high viscosity, and I use that to lift the iris and open the sulcus. But in front of that, I put 1.2%. Then I come in and I do all my endolaser. And when I'm done, I take the 1.2% out. But I leave the high viscosity behind the iris because it tamponades the ciliary processes. There's little to no fibrin, there's little to no flare, there's little to no hemorrhage if you leave that visco in. If you try to take that out, you're going to have more post-op issues in terms of fibrin and flare. But if I've used the high viscosity in the anterior chamber, I will take that out. That the body has trouble getting rid of that, and it's hard. If you get POH, it's hard to deal with if the high viscosity visco's in there. But I left the standard Helon sodium hyaluronate 1.2%. I left it in dogs for years. My POH was no different. You're going to get POH, period.
Thank you, David. That was great. Please excuse my fault with the introduction. I would have loved to talk about you. David is a great speaker, as we all noticed, and we really enjoyed the seminar. Everybody says, thank you, David, a great webinar. A lot of information speak. So I think we thank Envision now for hosting the webinar, and well, I thank everybody who listened, and I got many questions about how you can access the webinar afterwards, and there will be a link on the Envision webpage that you can access when you register to the webinar, and it will be open, I think, in several days. So check the Envision webpage.
Thank you again to everybody. Ingrid, thank you so very much for sitting patiently and moderating this. I really, really appreciate it. And again, everybody, please stay safe. All the best to all your families. Thank you.
Bye, everybody. Bye.
Bye.